Hello and welcome to Medic's Desk. Wish you all a very happy Doctor's Day. Special thanks to Dev who is behind the camera and recording all our good videos. So today we'll be studying the basics of methotrexate. So as we all know, methotrexate, it was introduced in 1948 and it has brought a revolution in the field of hemato-oncology due to its widespread use and the good results. It's an anti-metabolite drug and it interferes with folate mechanism like folate transport to the neoplastic cells. As we all know, these neoplastic cells, they are very active and they are continuously dividing cells, so they will need a lot of folic acid for DNA synthesis. What methotrexate does is it inhibits dihydrofolate reductase and thymidylate synthetase and alters the transport of this reduced folate to the neoplastic cell. So there will be no folic acid for synthesis of DNA, ultimately leading to death of the cell. So it's a cell cycle specific, basically acts in the S phase of the cell cycle. It's metabolized less than 10% into the liver, and the other it goes into the third spaces, for which we'll be seeing the side effects of this drug and the contraindications. It's excreted, 90% of it is excreted into the kidneys by glomerular filtration and tubular secretion. The T half of the drug is dose dependent. So if the dose of the drug is less than 30 mg per meter square, it has a half-life of 3 to 10 hours, whereas for the higher doses, the T half is 8 to 15 hours. What are the special precautions that we have to keep in mind before giving methotrexate to any patient? So if a patient is having pleural effusion and ascites, we should not give this drug, because as we have seen in the metabolism, it is less than 10% is metabolized in liver, while the other it goes into the third spaces, and if a patient is having pleural effusion or ascites, the drug will go to the pleural fluid or ascitic fluid, and it can cause increase in the toxicity of the drug. In elderly population, we all know there can be impaired liver and renal functions and can cause increased toxicity of methotrexate. In pregnancy, as we all know, it's a category D drug. All the chemotherapy drugs are category D drugs in pregnancy, so should not be used and cannot be used in the patient who is breastfeeding. So most important things we'll cover is the side effects and the high dose methotrexate and its mechanism, leucovorin rescue, will be covered into the next video. We all know bone marrow suppression is a most common side effect of methotrexate. So just to remember the nadir of the methotrexate, first nadir it comes generally in 4 to 7 days and recovery will be in 7 to 13 days, whereas second nadir comes in 12 to 21 days and recovery will be in 15 to 27 days. There can be some allergic reaction to methotrexate, and in such patients will not give methotrexate again to them. It can cause tinnitus. In cardiovascular system, there can be hypotension, pericardial effusion and pericarditis into the patients. There can be some dermatological side effects like skin pigmentation, Stevens-Johnson syndrome and TEN, as we all know. So fever and chills are frequently associated with methotrexate, and this can confuse us with any underlying infection. Fatigue and myalgia are also the common side effects of methotrexate. Coming to GI side effects, it's a potentially emetogenic drug and it can cause dose-dependent emetogenicity. More the dose, more will be the emetogenic potential. It can also lead to mucositis, anorexia, and in few patients, in less than like 10% patient, it can cause perforation. It's a hepatotoxic drug, and hepatotoxicity can be life-threatening problem for the patient. It can lead to increase in uric acid due to tumor lysis syndrome and can also cause azotemia. Azotemia basically means increase in the nitrogenous compounds into the body. In musculoskeletal system, it can cause myalgias, osteoporosis and soft tissue necrosis. That should be remembered. Coming to very important side effects, in central nervous system, the neurotoxicity is commonly seen, and it is more due to intrathecal administration of low dose of methotrexate. As we all know, the other side effects that can be seen in CNS are headache, it can cause seizures, there can be dizziness, there can be cognitive dysfunctions. Also, it can cause a severe transverse myelopathy. in ocular side effects, we should remember about blurred vision and conjunctivitis. Pulmonary toxicity is an important toxicity of methotrexate and should be remembered. There can be increased chances of opportunistic infections due to immunosuppressed conditions. There can be increased risk of lymphomas and interstitial lung diseases. And generally, we see the lung toxicities, they are common when the patients get small doses of methotrexate over a long period of time. Very important dysfunction to remember, the renal toxicities. So this is a very rough diagram of a nephron. This is a glomerulus, and we all know these are collecting ducts. So what happens is, we have seen in the excretion that it is excreted by glomerular filtration and active tubular secretion. So when methotrexate comes into the collecting ducts, if the media here is acidic, all the methotrexate, it will crystallize and cause renal injuries. So that's why whenever we give methotrexate in a high dose, we will make sure that our fluid will contain soda bicarb to alkalinize the media, so that the whatever the acidic medium here is neutralized, causing an alkaline medium, there will be no crystallization of methotrexate and all the drug will be dissolved and excreted. So just to remind everybody to remember, important side effects is the renal injury, the lung injury, that is increased risk of infections due to the opportunistic bacteria in the immunosuppressed individual. To remember in CNS side effects, we should remember about headache, seizures and dizziness, hepatotoxicity and high hematogenetic potential. And there can be fever due to methotrexate, which can lead us to any confusions with the underlying infection. So thank you everybody. We will be covering the next part of methotrexate in the next lecture.